Welcome to the External Medicine Podcast. I'm your host, Daniel Belkin, and this is my co-host and brother, Mitch Belkin.
We're resident physicians interested in medical innovation. This podcast is our attempt to explore new ideas currently on the outskirts of medicine. This is not professional medical advice.
This podcast is for educational and entertainment purposes only. We do not endorse any healthcare providers or treatments. Our views do not represent the views of any official organization or institution.
If you'd like to support us, subscribe to our podcast or leave us a review.
Or you can follow us on Twitter at EXMedPod and tell your friends.
We are here with Dr. Jason Ryan. Jason, welcome to the External Medicine Podcast. How are you doing today?
Great. Thank you for having me.
Before we get started, do you have any financial disclosures?
The only financial disclosure I have is that I own and operate Boards and Beyond. So that's it.
Great. Well, we're definitely going to ask you about that.
Good.
But before we do, can you tell us a little bit about your background? You studied chemical engineering in college. How did you end up switching from that into medicine?
Yeah, that's a great question. So there were a lot of pre-meds. My father's a chemist, and so I went to college thinking of doing something like what he did. And so I picked chemical engineering, and there were a lot of pre-meds in my classes, like organic chemistry and other classes. And I actually kind of thought they were annoying. They were obsessed with getting A's and getting into med school. But then I finished college at Lehigh, and I took a job at a plastics company, and it was a very cubicle kind of job, a very isolated kind of job. There was nothing really wrong with it. I just realized sort of it wasn't for me. I saw where the next 10 or 20 years of my life was headed doing that kind of work. And I realized I kind of sort of thought, oh, science is interesting, so I'll do science, but never really thought about how I would apply it. So I reconsidered the options, and actually the more I looked into medicine, the more interesting it became to me. So I took the MCAT, applied to med school, and I got into UConn and sort of switched careers to become a physician.
I have to just say, it is so weird to hear you at one-time speed. I'm so used.
I get that a lot. Yeah, I get that a lot. I get that all the time.
Yeah. So how did you end up choosing cardiology?
Another cool question. So I didn't even know what a cardiologist was when I started medical school. I don't come from a family of doctors. I didn't really understand all the specialties that well. And I'd heard cardiologists get woken up in the middle of the night for people with chest pain. So it didn't sound like a very exciting field. But in my third year, I had an internal medicine rotation where a half day a week, I went to cardiology clinic. And that was really the first time I sort of saw what cardiologists did. And I thought it was a really cool mix of bedside medicine, like the physical exam mattered, the history mattered, but also high-tech stuff like echocardiograms and angiograms and pacemakers. So I really liked this mix of techie stuff plus good old-fashioned doctoring. And so after that, I kind of kept comparing other fields to cardiology. And there were other things I liked a lot. I really loved general surgery. I loved OBGYN. But in the end, cardiology just kept winning out. And as you know, you don't have to decide. You can match into residency for internal medicine, and then you apply to fellowship in cardiology. So I decided to go into IM and then eventually applied in cardiology.
Just want to jump back and ask a quick question about your decision to go to medical school initially. My understanding is that your grandmother was a general practitioner in Virginia and graduated medical school, was it in the 1940-ish?
That's right. That's right. Yep. No, you've done your homework. I'm very impressed on me. Yeah, my grandmother was a physician in Charlottesville, Virginia. She graduated medical school in 1941. She was one of the first women graduates of her medical school. And she was the only other physician in my family. And she was really people don't practice medicine like she did back then. Her patients all had her home phone number. If someone went to the hospital, she would tell them to go to the hospital and then go and examine them in the emergency room and write the orders and admit them and see them each day. So she really had this old-fashioned small town doctor kind of practice. I still have a lot of her. She passed away 10 or 15 years ago, but I have a lot of her old books. They're very cool. Her microbiology book has a great sentence that says, It's unclear if the nucleus of the cell has any relevance to life function of the bacteria, because, DNA hadn't been discovered then. And I have her book. She subscribed to a publication called Disease a Month. And I have the one on heart failure and the one on coronary disease. And it's pretty interesting. They actually understood quite a lot about what causes heart failure, what causes heart disease. But the section on treatment is, half a page, because there just was like really nothing you could do except bed rest and sodium restriction and things like this.
Bed rest. That answer that's always wrong whenever it appears on US.
That was the original beta blocker, was bed rest. They just wanted to, the book is all about keeping the heart rate low by restricting activity. It must have been torture to just sit in bed for 2 weeks after a heart attack, but that was what you had to do.
Let's talk a little bit about Boards and Beyond. I know that we mentioned it in the financial disclosure section. I know that we're going to mention it a bunch more. Every medical student or recent medical graduate knows exactly what Boards and Beyond is, but for practitioners or physicians who have been out in the field for a little while, how would you describe what Boards and Beyond is?
Yeah, so Boards and Beyond is a website that medical students can subscribe to, and it gives them access to my teaching videos and practice questions that go with those videos. And so it's filled with a lot of 15 or 20-minute videos that I've made on all the topics med students need to know, everything from heart failure to biochemistry to what have you. And so it started as a little side project of mine. I never thought it would get as big as it is today. I just like to teach, and some of my students said, you should record your videos. People would love to listen to them. And I hired some people to build a website, and then I just started making more videos. And it took a long time to catch on. It really was, didn't sell much at all for the first year or more. But then as I made more videos and word of mouth happened, it started to catch on. And now, of course, it's this big behemoth. It's got hundreds of videos and practice questions, and I have people that work for me. But it started as really this small sort of side passion of mine.
Was Boards and Beyond the first entrepreneurial venture that you had ever undertaken, or are there other things you worked on in the past?
No, it was a leap of faith. I'd never done anything like this. I had a lawn mowing business when I was 12, so I guess there was that. So I've always been the kind of person who has, sort of their eyes open for side opportunities. I love medicine and practicing medicine, but I was always the person who was joining the committee to do something new at the hospital, or, I was chief resident. And so I always had an interest in these side gigs, but I didn't know anything about running a business, starting a business. I had to learn all that from scratch.
You said that you started Boards and Beyond a number of years ago, around 2014-ish. And can you tell us a little bit about the process of actually getting off the ground? You hired somebody to do the sort of web development portion of it. Were there other people involved, or was it just a two-person operation initially?
Yeah, that's a great question. So there was another website already existing called Pathoma, which you've probably heard of. It's a website made by a pathologist in Chicago, and he has about 75 or 80 of his own teaching videos. And I was blown away that students at UConn were subscribing to this. And the more I looked into it, I saw that students around the country were subscribing to his website. And so that was really a light bulb moment for me when I learned about that. And also some of my students said, Dr. Ryan, you should do what Dr. Sitar did with Pathoma, because your teaching is really good. So that gave me the idea, but then actually doing it was a huge undertaking. So first I had to find a way to make videos. And so it turns out this is pretty easy to do now with some relatively inexpensive software. I use a program called Camtasia. It records my voice over PowerPoint slides as I move through the slides. It also records any writing I do on the screen with my mouse. So that allowed me to pretty easily make videos. So that was the first thing I had to figure out. Then I needed a website where students could subscribe. And I didn't know this, but a lot of websites are really glorified magazine ads. They're pretty pictures, there's lots of words, but the amount of interaction is low. A website that can accept credit card payments and stream videos at multiple speed playbacks is very sophisticated. So I had to do a lot of calling around to different companies, and The original website, which is far less sophisticated than the one that's there now, cost about $15,000 to get off the ground. And, at that time, that was a big chunk of our savings. I was a few years out of fellowship. We were doing fine financially, but, to give away $15,000 when you never know if you're going to see any of it back is a leap of faith. But, I have a very supportive wife, and we talked about it and thought this was worthwhile. So we did it. And so they built the website for me, and they were great. And because I don't know anything about it, and there's a couple of them, and they work on it, and then they show me what they did and ask me if I like it. And so we got the website up and going, and nobody bought it. That's just, because it was new and no one had ever heard of it. So I spent a lot of months just giving it away for free to people. And I think it took about 3 or 4 months till the first person ever bought it. I got an email saying someone had paid for the website. I actually thought it was spam or something was wrong. And then I read the email, and I said to my wife, I said, "Oh my God, I think someone paid for Boards and Beyond. I can't believe it." And then, we had many months where like 3 people a month would sign up, or 4 people a month. But I didn't know, I saw that people were watching the videos because we could see the counts. So I knew nobody hated it. They just weren't ready to pay for this yet till they had seen their classmates try it out. So it took a while for it to catch on. But then it really took about 2 years till it started to sort of go viral as more and more people had used it.
That's so interesting. Did you, at that time, were you handling all of the business aspects of this as well, in addition to making the videos? Were you adding videos during that time, or did you kind of just make something very self-contained and watched it take off?
So initially, it was just going to be a cardiology website, like a cardiology version of Pathoma. But I kept getting emails saying, my school doesn't teach us renal physiology at all. And I had taught some of that to students. Or we don't get any neurology. And, I'm not a neurologist, but I know enough to teach it at the step 1 level. And I had colleagues who could help me make the slides. So I started realizing I can actually make content on anything as long as I ask friends of mine to help me with the slides, and then I present it. And so during that whole time, I was adding content steadily but surely, so that every month there were another 10 videos or so that would go up over time.
One thing that I noticed you say a lot is student feedback has played a big role in implementing various changes. For instance, favoriting of items, playlists. All of those were specific user suggestions, and even the decision to add on other subjects came from students. How do you go about incorporating student feedback? Is it purely like you wait for somebody to email you? Are you going out and finding people that have used Boards and Beyond to solicit feedback? How do you think about that?
It's a little bit of all of those things. I interact with the students at UConn a lot where I teach. So I pick their brains, and they come by my office to talk about something else. And we end up chit-chatting about Boards and Beyond. A few times we emailed some surveys to ask people what they'd like to see more. And then, when the 4th person emails in saying, I'm frustrated you don't have this feature, it would be so much better if you did, we start to notice and say, okay, we're going to do another upgrade in 3 months. Let's roll that into the website. We really made a big change happened in 2020. We switched companies who run the website to an entirely new company. They're based out of New York and India. It's a much bigger company, and they rebuilt the entire website. This was a huge investment to take it to, because we kept having overwhelming traffic that was bogging it down. And so when we did that, we basically rolled in like 50 different upgrades that people had been asking for into the changeover. So the new website had a new look, and it also had a lot of new features that people had been asking for a long time.
And all of the videos are you. Do you still make all of the videos yourself, or do you have people helping you in that process, and you kind of come in at the end and put everything together, and then you're the pretty voice at the end of the day?
Because I give the talk, I have to know the video, the slides, and the topic. It wouldn't be the same if I knew nothing about glycolysis and I was just reading the slides to you. So I have a process. I dust off my old textbooks. I refresh myself on whatever biochem pathway I'm teaching, and then I make some slides with or without help from another content expert expert. It depends on the topic. But for a lot of topics like dermatology and endocrine and orthopedics, I have someone who works with me and helps me make sure the information on the slide is right. And then I give the talk myself. I have people that help me edit the video now. I mean, I used to do all this myself, the editing and everything. I have people that help with all those steps now. But ultimately, I think part of what makes a video effective is if the person presenting the material, you feel like they know it. You feel like you're having a conversation with someone who knows the material. So people have asked me, why don't you hire a voiceover person to do the videos? And I don't think that would work, because you want to feel like I'm talking to Dr. Ryan. He's explaining cardiac physiology to me the way he understands it. And that is what I'm doing. Even if it's not a topic I'm an expert in, I've brought myself up to speed on it enough that I can explain it to you in my own words. So you're really getting an explanation from someone who knows the material.
Have you considered branching into other languages?
Well, we added captions, another student suggestion, a few years ago. And so we could, get captions in different languages. We do find, though, that the people that subscribe to the videos outside the US are trying to come to the US for training. They're international medical graduates who want to apply to residencies in the US. So they actually want to hear the videos in English because they're going to take the tests in English. So we have considered it, but I'm not clear yet if there's a lot of demand for it in completely different languages.
What would you say has been the most surprising thing you've learned from creating and then growing Boards and Beyond over the last 7-8 years?
Yeah, I mean, probably the biggest thing is how much demand there is for good teaching in medicine. Teaching is, I don't want to paint too dire a picture, but it sort of is dying. The faculty that are asked to give lectures are strapped for time. They have to see more patients, read more radiology images, write more research grants. And so the teaching keeps falling to the bottom of the barrel. And so students have emailed me saying, we get one lecture on cardiac physiology by someone who's a PhD without a background in the area, and that's it. And then we're on our own. We were supposed to get a lecture the other day on pulmonary physiology, but the attending showed up late because she had a patient and then got paged and left after 20 minutes to go back to the hospital, and the lecture was canceled. These kind of stories are just everywhere in medicine. And so I think that's a huge part of what's driven the demand for Boards and Beyond, is people are looking for somewhere they can go that's easy to access, it's on demand, they can watch it at night or in the mornings, and it just delivers, concise, clear teaching. I don't think my teaching is perfect, but usually it's within some framework of, some lectures are very good, some are mediocre, but none of them are horrible. And you just know you can kind of get some halfway decent teaching from Boards and Beyond, and people just love that. And I think that lots of areas of medical education are ripe for this kind of change.
I'm curious what the general response has been from clinician educators, either at your home institution or other institutions. You're essentially teaching subjects that every medical school in the country is required to teach, and oftentimes your teaching is better. Have you gotten any pushback, or what has the response been from others?
The most common response is just indifference. Most faculty, even at UConn, don't really know they think I make YouTube videos or something. I've seen them come up to me and say, what do you do? Is this a YouTube thing or something? And they don't really understand. There are a few of them that get it, but mostly I think, like I said, faculty are just too busy. And so they show up, they give their lecture, they leave, and they don't have a lot of time to think about it. So if the students are ignoring their lecture and going to mine, a lot of them don't even know that that's happening. If they do, I haven't met too many who are too offended by it. They sort of think of me as a board review book, like, oh yeah, okay. Students are always going to go to these outside quickie resources for extra facts. So only students who have really trained in the last 5 years or so sort of understand the role that Boards and Beyond could play in educating a medical student. I think anybody who trained before that doesn't quite understand what I do.
So what do you think the future of medical education resources like Boards and Beyond, like Pathoma, Sketchy, Pixarize, where you pay for it, it might be a couple $100. It's much cheaper than medical school tuition, and what you get from it is usually sticks in your mind better and is overall better. So what do you think the future is for these products?
I mean, I hope someday a medical school will realize that for a lot less money, they could train students, especially for the things they need to learn that are foundational concepts, like in the first 2 years. But I haven't seen much evidence of that. Medical schools are large, entrenched institutions, and these types of things take a long time to change if they change at all. So I think at least for the near future, there's going to continue to be this parallel curriculum where the school is teaching students in one way. It's somewhat helpful. The students interact with it somewhat, but then in parallel, students are doing their own learning with these outside resources. Some institutions are buying Boards and Beyond for their students, but they aren't really replacing their curriculum with it. They're just buying it for their students so they don't have to buy it for themselves, sort of as a financial service. I think it's going to take until your generation of doctors is running the medical school, maybe in 10 or 15 years. And then somebody might say, okay, maybe we could teach biochemistry with a product like Boards and Beyond instead of teaching it ourselves. But it's really tricky because the med school has a budget and they've hired people to teach biochemistry. And it's hard to just say, I'm sorry, we're not going to employ you anymore because we found a website. So these things are very, very messy and complicated. And a lot of students have said to me, why don't med schools just tell us to go watch Boards and Beyond and not charge us for the first years? And I think it's going to be really hard for something like that to happen, or at least take a long time.
So Boards and Beyond was originally a resource to study for USMLE Step 1, which went pass-fail a few months ago. What are your thoughts on Step 1 going pass-fail?
Well, I think probably overall it's a good thing because it had gotten out of control. Students were arriving at UConn studying for Step 1 from the first day they walked through the door. We had people emailing us in college saying, I just got into medical school. Can I have a discount on a subscription to Boards and Beyond so I can start studying for Step 1? It was just the test was taking all the oxygen out of the first 2 years. People were skipping their clinical skills because that's not on the exam and they wanted to study physiology or what have you. So, and then I think also the stress level of all that pressure was just really driving students to a point of anxiety and depression that was really hard to deal with. So probably it's good it went pass-fail, but residencies still have to evaluate you somehow. If you're a dermatology residency that gets 500 applications for 3 spots, you can't read all those applications. It's not possible. Even if every one of your faculty members took 10 charts, it would just take forever to get through the whole 500. So they need a screening tool. So this is still going to continue to go on. Students are going to be screened probably by their Step 2 score, by the number of honors they got, based on the institution that they attend and how familiar the residency is with that. So it's nice that some of the pressure of the first 2 years has lessened, but it hasn't fixed the fundamental problem, which is that there is just more interest than there are training spots in a lot of these highly paid specialties.
A question about board exams. One thing that's sort of interesting to me about studying for Step 1, Step 2, and I guess in the coming months, eventually Step 3, is they very much differ from the actual practice of medicine in that when I want to know the answer to what antibiotic to use, I literally will just pull out my smartphone and look it up. Should board exams allow you to use your smartphone in order to actually mimic the current practices in medicine?
Oh, God, yes. I mean, it is ridiculous. This test that you take now would have been perfect for my grandmother, all right? If she wanted to look up what antibiotic to use, she would have to go to her office, find some volume of a textbook, open it up, and it would be impossible to do while also treating patients. So it made a lot of sense in 1941 that you had to memorize everything and have those answers at your fingertips. Now it makes no sense, right? What you need, you don't need to know how to tell type 1 glycogen storage disease from type 2. That's ridiculous. You need to know that glycogen storage diseases exist and you need to think of them and go look them up and up to date. But the things you're required to memorize are just so out of step with the modern practice of medicine. And I just don't know why this won't change. I've run into a few people who've given talks at conferences I've been to from the USMLE, and I've asked this question, and they've usually given me a sort of evasive answer that there are no plans to make the test open book. But I'll really never get it because you're right. it would be much more accurate to test, can you quickly look up what antibiotic, because that's what you need to do taking care of patients, versus do you have it memorized? And I wish these tests would change, but they're all mired in, they're anachronistic. They're tests that would have been appropriate 40 years ago, but they really don't match what we do today.
Yeah, and knowing what to look up, where to look it up, and how to look it up is a big part of what you do. You kind of build these mental maps that you can then return to, but you don't need to hold all of that information in your head at all times.
So when I was a third-year resident, I had matched into cardiology. I was at the Beth Israel Deaconess, and I'd been asked to be chief resident. And I felt, probably overconfident. I was in that resident phase where you just feel like you know everything, because I was really good at functioning in the hospital. I could admit patients quickly. I knew how to call the radiology reading room for a wet read. I was just ready to go. So they gave us an in-service exam, which, was supposed to be a practice test for the boards, so you could identify your areas of strength and weakness. And I didn't study because I felt like I was a super resident. I almost failed the thing. I was stunned. I couldn't believe it. And it was because, I didn't know the 11 criteria of lupus at my fingertips. I hadn't studied any of these things. The 9 criteria of liver transplantation, I knew how to look them up. I could do it in a second. And they weren't asking me questions about real life as a doctor. What they like, if they had asked, what's the number for the radiology reading room, I would have nailed it, right? Because that's really important to know. That's how you take care of patients. But that wasn't on the test. So that was a huge wake-up call for me, where I realized how different boards are from real life. And you can really be an excellent clinician and do poorly on the boards. And so this is something I always tell people, if they don't do well on boards or they struggle, is you should never feel bad. It doesn't mean you can't be a good doctor, because the skill set required for doctoring is very different from the skill set required to answer board questions.
So it seems there are 2 parts to a student's application for residency. There's the sort of more objective portion, standardized testing, that's like shelves and USMLEs, and then a more subjective portion where you have like written evaluations by the various people you work with, attendings and residents. And there are problems with both of these parts. A lot of people I see on Twitter focus on the problems with the objective portions, and I feel like less attention gets paid to the problems with relying hugely on subjective evaluations, which are subject to bias, not just for for people who are similar backgrounds to the attendings and residents, but also like who's the most extroverted, who's the most attractive, and then also like if you're on rotation with this person versus that person, and if they're like doing 20 things more than you, how do you look in comparison and stuff like that. And it seems just in general that neither the objective nor the subjective completely capture all of the things that we care about for becoming a physician. But I'm just curious, like, what are your thoughts on balancing these 2 things and how we can better evaluate, future physicians moving forward?
Yeah, it's a good question. The problem with the written evaluation part, I can tell you from the perspective of an attending or a faculty member, is that unfortunately, like 95% of medical students look similarly. There's a small sliver that are off the charts. They're so good. You've hardly ever met someone like this. And there's a tiny sliver who are a disaster. They don't show up on time, but most people, when you spend 2 weeks rounding for an hour a day with a medical student, for about 90% of the people, they're going to be in that big chunk in the middle. So it's really hard for me to. I have
a quick story about that. I know from talking to my classmates, there are some people like whose names got mixed up. They wrote the wrong person's name on the evaluation. And then there was one person I know who got literally like blank was a fantastic student. Like they didn't even write the name. They just drew a line and said like, basically like fill in the person's name.
My MSPE, my dean's letter, used female pronouns during certain portions of it.
Yeah. No, and I mean, this is the problem. Like, if I worked with both of you guys on a rotation, you'd probably both do a decent job. Probably neither of you would be the best I'd ever seen in my career, or the worst. And so how do I tell a residency, okay, take one of you and not the other? You're better than him. It's very difficult to do this. This is just a human problem. And so that's why we rely so heavily on these objective measurements like board exams and shelf exams, because the subjective is really just never going to be perfect. And this is true everywhere. If you talk to people outside of medicine, they get their annual feedback, and it's, they don't get anything great, they don't get anything bad, and it's because the boss you're just doing your job. The boss can't really say anything about you that sets you way apart from someone else. So it's very hard to separate medical students in that big group in the middle, to put one above the other. And I think that's why the subjective one, I mean, honestly, almost everyone that's applied has a letter saying they're outstanding, recommend without hesitation. And that's good. I mean, it lets me know that they did a decent job working with this one attending. But when I'm comparing 3 different applications that all say those same adjectives, what am I supposed to do to decide which of those people I'm going to interview or not?
What do you think about the idea of, you could just have like someone speaking, like have like a small recording of a part of an interview already there, and then you could kind of see. I mean,
Yeah,
then people could work on their like personal videos
right.
and stuff like that. There would be a problem with this also, but you could kind of get a sense of like who the person is by, we should just film everyone all the time
Yeah,
and then
you could.
edit it into I don't know.
Even if you do that though, so we interview people for the cardiology fellowship, and I've had people where I find the applicant not very impressive, and one of my colleagues says, oh, that person was one of the best I've ever seen. And it's because all of us have different interests. For example, like I often ask students to tell me an interesting case they've seen. And one thing I like to hear is some talk about like the patient and the family's feelings, and how they interacted with them and put them at ease. I care much less about like which catheter the cardiologist used or which wire they used to access that. I'm much less interested in that. But I have colleagues who are completely the opposite. They are, if the applicant can name which 3 settings on the ECMO machine they use, they're like over the moon, and they aren't really as interested in that. So we even find in our meetings we disagree where everyone evaluates someone. So a lot of your application also depends, and this is also true in real life outside of medicine, but it depends on who evaluates you and what their priorities are and what they place the most weight on.
So let's imagine that you were to start your own medical school. What would you do differently than is currently done, and what would you keep the same?
I mean, I've had conversations with colleagues about this. I think if you gave me a really bright college student, really smart, eager, good personality, easy to interact with, and just let them follow me for 2 years, I could teach them to be a cardiologist. I mean, this is sort of the elephant in the room in medical education, is we spend a lot of time learning stuff you're never going to need to know. Now, would that person wouldn't have delivered 20 babies like I did. They wouldn't have sat in the radiology room reading CAT scans for hours like I did. But I would tell them about those things. I would make them go home and read about pregnancy and read about radiology. So in my ideal world, we would just trim training down much more and just cut out a lot of the slack. I don't think this will ever happen, by the way. This is just this sort of fantasy I have. But what's happened is 60 years ago, you had to learn everything because there wasn't that much to learn. That was all there was to being a doctor. And then as we discovered more information, it just kept getting piled on and piled on. And now, you're spending 7, 9, 12 years to become a specialist, when really you could do it in much less time if you just focused on what you're actually going to do as an attending physician. Now, a lot of people disagree with that. They say, I've saved a life because I saw a case that reminded me of med school where I saw someone in pediatrics clinic with XYZ. And so if you feel that way, then my idea is obviously bad. But I think you could really narrow medical education way down if you just focused on the practical aspects.
So you mentioned delivering 20 babies. Talking to many of my classmates as well as colleagues at other medical schools, I get the sense that actually getting to deliver a baby is increasingly uncommon. Like you might get to deliver a placenta.
I
You
see.
might get like a hand on hand.
Yeah.
I mean, if you're going to OBGYN, like maybe
Right.
during your 4th year, they give you more
Right.
experience with it. But talking to older physicians, they just delivered a lot of babies. And I'm curious, like, do you feel like medical student hands-on experience has declined over time? Do you feel like,
Oh, yeah.
when someone starts as an intern, they're less prepared now than when you were starting as an intern?
Oh, yeah, for sure. I mean, a dirty little secret of medical school is that it's very hard to find preceptors. faculty feel that a med student slows them down. So it's harder and harder to find a faculty member who's willing to take a med student who's going to be tagging along and asking questions. And so this trickles down into the teaching. You could take 20 minutes for an important part of the delivery by letting the medical student put their hands on things and try things, or you could do it yourself in 5 minutes and get on to the next case. And when they're monitoring the number of patients you see and they've tied a fraction of your salary to that target, then you can just imagine how over time letting medical students do things is going to dribble down. And we see that all the time. It's very, very difficult to find spots for medical students to go. In the state of Connecticut, there are some new medical schools that have opened up. Some of them have a lot of money from funding, and they're basically buying out the preceptors from the state medical school, saying, we'll give you $1,000 a year if you take our students, and the state can't match that. So there's this secret competition going on for the limited number of attendings who are willing to take the time and teach medical students.
Interesting. On the topic that we were discussing earlier about medical school costs, med school is getting more and more expensive. In this new medical school that you're founding, what are
Which
your...
they'll never let me find, but yeah, if I could, yeah.
What are your thoughts on reducing med school debt?
Yeah, I mean, it would be great to reduce med school debt. If you could shorten med school to 3 years, I think that would help a lot of people. A lot of people in my family went to graduate school for PhDs. So, everyone gets saddled with debt. Doctors at least are able to usually pay it back. They're going into a relatively lucrative field. So, I think that everyone should have less debt, ideally, or their debt should match their earning potential once they get out. But anything you can do to shorten the debt burden on people who attain higher education degrees is fantastic, because it does affect people's choices of where to practice and how they can live and things like that.
Medical schools are increasingly, cutting the 2-year preclinical curriculum down to 1.5 years or 13 months or 15 months. And there are even some schools that are offering 3-year medical school curricula for, I think if you're definitely going into internal medicine or family medicine or something. You mentioned previously about 4th year, basically just, and this might've been before we started recording, I forget, but you were saying 4th year is just, not doing much, not a whole lot of learning while you're interviewing, and you do your required acting internships, and then you watched two seasons of The Sopranos on VHS.
Yeah, that's what I did. Yeah. No,
So,
4th year is like senior, it's like the last 6 months of college. It's fun. You're not being evaluated, but you don't learn a lot in those 6 months. And most of what you learn, you're just going to see again in internship anyway. You might do a sub-I, and it's exciting. I mean, one thing I do want to say is I loved med school. It was so much fun. I love delivering babies, even though I'm not an OBGYN. I scrubbed in on a liver transplant and a kidney transplant, and none of those things helped me that much to be a cardiologist, but I was so grateful for the experience. So it's not like it's bad, but if you really want to just train doctors quickly and decrease debt burden, I think you could do it a lot faster. And 4th year of med school is one of those things we talk about a lot, where a lot of people, you probably now are ready to go on to internship if they would let you, but you're going to have to arbitrarily wait until July 1st because we want you to finish this 4th year of medical school.
Yeah, I mean, it seems like it would be very easy, similar to college. Like if you want to do some extra credits, be my guest. But if you don't, if you want to just start, that would also be nice to have only 3.5 years of debt rather than
yeah, it'd be great. I mean, again, it's just a big cumbersome system, med school, residency training. It's got hundreds and thousands of people working for it. It's set on a certain timeline that it operates on, and it's just very hard to change that, even if it might make sense to do that.
So some people on Twitter believe that the match should be amended or completely eliminated. I'm not really sure what I think of this. It seems reasonable. If you were going to cut, half of 4th year off, you could have 2 matches, one match that you start January 1st and another match that starts July 1st for people who are finish early. But I'm curious if you have any thoughts on the match as a sorting algorithm for residency.
I've sort of avoided weighing into the match debate. The reason being because what little I know about it is it's like a super complex, Einstein level math problem of how many applicants, how many spots. And, if you didn't have it, if you're a really strong applicant, you'd obviously be fine without the match, because people would want you. If you're an average to below average applicant, you could be in a worse place without the match, right? Because no one would offer you interviews till all these high end applicants went first. So I don't really know how much better or worse a world without the match would be. But I know there are a lot of people who've done a lot of math problems to try and look at this to see which way is better than the other. It is crazy, though, that you sort of stick your name into a computer and it spits out where you have to go to work. I think to the average person, that just comes across as a crazy way to do things, but it is the way we've done it for years.
Changing topics just slightly, in the early 2000s, you wrote an article about the unintended consequences of the 80-hour work restriction. Could you talk a little bit about your experience living through that change, and how have your thoughts on the 80-hour work week changed between then and now?
Yeah, that's interesting you brought that up. So I had no work hour rules for my first 2 years. And then in my third year, we did have work hour restrictions. And so I wrote this article about my observations, and the work hour restrictions were great for letting me go home and sleep. But I did sometimes used to hang out in the hospital, beyond when I needed to. And we all of a sudden had program directors and other people rushing us out the doors because these requirements were being monitored. And so that was a change. No one had ever done that before. No one had ever discouraged a resident from staying longer to help. So that's what I basically wrote about in that article, is about a patient coming in. I began the workup, and then all of a sudden it's time for me to leave. The work hours have become the norm. So, they're here to stay, and they're not going anywhere. I think on the whole, they're good because they let people get home and get sleep and get rest. There were times that I stayed in the hospital way too long, probably like 40 or 50 hours, but I loved it because, there were 3 STEMIs that came in a row, and I was floating temporary pacemaker wires and managing ICU patients. And I just had a blast doing it. But that's my own personality style too. Not everybody feels that way. So, I think they're here to stay, and I think they're a good thing so that everybody can sort of live their life.
All right. We have a few rapid fire questions for you.
Shoot.
Do you have any advice for any aspiring physician entrepreneurs out there who see what you've done with Boards and Beyond and are like, wow, I want to do that?
Yes. So I'm not sure why more people aren't doing what I did with Boards and Beyond in other fields. It is slowly happening. But for example, a friend of mine, she's board certified in palliative care medicine. They have their own boards. And she has to recertify every 10 years. And the only way to study for these is to take an online course for $2,500 or so. Anyone who knows palliative care medicine could make a 50 video Boards and Beyond type website and sell it for $200 and put that company out of business and pay off their mortgage with the revenue. I don't know why someone hasn't done that. The same is true in lots of other fields. When I took the echocardiography boards in cardiology, I flew to Chicago, stayed in a hotel for 3 nights, and went to a course down in the lobby every day. It probably ended up costing me a couple $1,000s. Someone could make an echocardiography Boards and Beyond and sell it for $150. And keep in mind, medical students have a limited ability to pay, but you can charge attendings, $500, and they're more willing to pay it. They have salaries, and it's still less money than what they're being charged. So all the fields in medicine that have board exams are ripe for this. If the right person with the right motivation comes along. And I'm not sure why more people haven't done it. I don't know if they think it won't work in other fields or they don't have the time to make the videos. But if you're feeling burnt out and you want, to cut back on your clinical medicine, just take a look at the board exams in the field you're in and see if there's a way you can start making videos. Because the videos are really, really easy to make. Once you get the hang of it, in about an hour, I can make a 15-minute video once I get the hang of it.
10 years from now, on Boards and Beyond, you've met every single goal that you've set. What does that future of Boards and Beyond look like?
The future is that it has to become not just Dr. Ryan's website. So the next era is to try and find other physicians who can update videos instead of me, but use my style and have the quality be maintained. And so, I think that'll be the push for the next few years. We're also starting to make some videos for the wards. We call it the ward series. So these won't be made by me, although I'll help the people who make them. But, one of my students told me on his first day in medicine, there was a patient with hyperglycemia, and they said, "What do you want to prescribe?" And he said metformin, because that's always the answer on UWorld for the first drug. And no one had ever told him that in the hospital, we never use oral drugs for treating diabetes. We always use insulin. And he's a really bright student. He went into dermatology. This was not a lack of knowledge. Just there's this different way we practice medicine in the hospital. Students of mine, even fourth years going into surgery, come to me and they don't know the difference between the different types of central lines, the different types of drains that are used. So there's all this practical stuff that you just learn by osmosis. And we're going to see if we can capture it in a short video series, some of them for medicine, some for peds, some for surgery and OB/GYN, because I think students more and more want to be up to speed before they go into the wards on their rotations.
What important medical truth do very few of your colleagues agree with you on?
Good question. Let's see. One thing I will say is I think we overtreat and overdiagnose in medicine, and it's to the detriment of a lot of patients. I practice a conservative style of cardiology. If someone is having a myocardial infarction and needs an angioplasty, I always want them to have it. But if someone is a borderline case and is likely not to benefit, I will err on the side of going conservatively and trying to keep patients from experiencing unnecessary tests and unnecessary procedures. There are definitely lots of cardiologists who don't agree with me on that. All the tests, all the procedures for all the patients all the time. That's not the way I practice. I really try to teach the fellows, especially in cardiology, we deal with a lot of elderly patients. They may have limited mobility. They're not going to get angina because they're not going to go climb a mountain or something like that. So we really talk about what's your goal with a catheterization in this patient? What's your goal with a stent and different medications? And so there's definitely a divide, especially in cardiology, but in all of medicine, over how aggressive is appropriate, especially for elderly patients.
Do you have any other future projects outside of Boards and Beyond in mind?
So I joined a men's basketball league like a year ago, and I was so rusty at basketball, and a lot of the people are younger than me, and it was really embarrassing. And I am determined to push myself up to be at least a solid middle of the pack by a year from now. So the gym I go to has a basketball court, and I spend a lot of time practicing my free throws and 3-pointers. And so if you ask me my goal for like the next 6 months, it's that when the next winter league comes next November, I'm going to be better than I was last year.
As last but not least, was there anything that we didn't have the opportunity to get to today that you really wanted to talk about in this discussion?
No, I'm glad you brought up what other entrepreneurs can do. I really think that medical education is an untapped possibility for people. A lot of physicians, do side gigs where they do medical legal consultation or they do insurance evaluations. But there is such a demand for good teaching that's not being met. And as we've discussed, the quality of teaching is sometimes drifting down because physicians are just too busy. So if you feel like you're good at explaining things, and especially if you have some experience teaching and you've been told by students that they really like your style, they really like your explanations, that skill is really valuable in the next 10 or 20 years as more and more teaching moves online and people are looking for ways to learn. So I think every practicing physician should think about it if they have the ability to do it.
All right. Well, thank you, Jason, for coming on the podcast. For people who are listening and they're going to look you up later when they get home after their commute, where should they go on the internet?
You can just go to boardsbeyond.com is my website, and you can see all the content we have there. There's a bio of me. And if you want to know more about the business and the website, that's where you can find it all.
All right. Well, thank you so much for coming on the show.
Thanks for having me. My pleasure.
If you'd like to support us, here are some ways you can help. Subscribe to this podcast wherever you get your podcasts. Leave us a review, preferably a phenomenal review. Visit us at externalmedicinepodcast.com and tell your friends.